Good morning, everyone. Today we are going to discuss about the rickets, and we have a faculty, Dr. Nisha Bhavani. She is a professor in Department of Endocrinology, Amrita Institute, Cochin, and she is going to talk on the rickets. What is the beyond? What is the next treatment in the rickets in this ESICON? But in our this interview, we are going to talk on the very basic aspects of rickets. So, ma'am, I would like to begin with the very basic things, which is the most common cause of rickets, and we know it is a vitamin D deficiency. So, do you feel that it is the still most common cause, because nowadays vitamin D deficiency is easily corrected by vitamin D supplementation, and there is a lot of awareness about vitamin D. So, still in this era, or still in our developing country like India, vitamin D is still a most common cause for the rickets, or nutritional, I will say. So,
I think the nutritional rickets in the weaning period has become less nowadays because it is a uniform policy that all breastfed infants are being supplemented with vitamin D.
yeah,
So probably in that age group the incidence is coming down.
okay,
We don't have any hard data to support that, but from my experience I am telling. But then in other age groups like the toddler age group, when people start like children above 1 year of age and all, it is still very common because of the food fallacisms and because of the they don't drink milk, they don't take vitamin D. So this uniform vitamin D supplementation is recommended only till 1 year of age. So
Okay.
beyond that, still calcium vitamin D deficiency is very common, and we are seeing many number of cases of nutritional vitamin D deficiency in that age group. So below 1 year probably it is becoming less common.
Less
Above
common.
1 year is still the commonest cause, and probably if you take on a community basis, it is still very common, especially among the underprivileged community.
okay. So, everyone is now aware, a general practitioner also aware of rickets. They know all the common symptoms and signs of rickets. So, but when to suspect other kind of etiology in rickets, ma'am, apart from the nutritional, which are the other common causes, and when we should suspect in such cases?
So by far the commonest cause is nutritional calcium vitamin D deficiency. So for a general practitioner, for a general pediatrician, vitamin D calcium deficiency is the commonest form of rickets. All other rickets combined together will constitute only a very minor percentage. It is important to recognize them, but it constitutes only a minor percentage of the rickets.
Okay.
So you should suspect, we can suspect them. As I said, nutritional calcium vitamin D deficiency is common in certain age groups at the time of weaning, or at the time when child starts to take its own food, at the time of puberty, at the time of pregnancy.
Okay.
So in such situations, and in exclusively breastfed infants, if they are not being supplemented with vitamin D.
Okay.
So these are the times when calcium vitamin D deficiency is more common. So when rickets occurs outside of these age groups, you should always suspect some other forms of rickets. And then depending on, so age of onset is one, and period when rickets gets manifest is the most important thing. Then you can go into the other details like family history. If you have a family history of someone with the same problem, bowing of legs, you should suspect some form of hereditary rickets.
Definitely.
Then consanguinity in the family. If you are the product of a consanguineous marriage, you should always suspect. And then other associated diseases like renal disease or any other disease which you have, it's not occurring in an otherwise healthy child, then we should suspect other forms of rickets. So these are the common situation, and then the most common thing is probably if you are not in a place where you have investigations to work up for resistant rickets, if your rickets is not healing with a conventional treatment in 3 to 6 months time, you should always suspect rickets other than nutritional calcium vitamin D.
Okay.
And of course the investigations are the one which will help you to finalize your diagnosis.
Okay. Many of the time primary physicians, by looking at the history or by examining the child, they diagnose the rickets, and with few investigation or minimum investigation, they empirically also starts with the vitamin D supplement. And if they are not improving with, as you said, within 3 or 6 months of time, we should suspect the other cause of ricket. So, and in that cases, madam says that apart from vitamin D or calcium, the genetic cause or hypophosphatemic rickets or renal rickets are the obvious causes where we should look, and where the family history is very obvious. So, ma'am, which are the basic minimum test we should do while evaluating the rickets? Many of the time, physician only do the calcium, vitamin D, and max to max X-ray or alkaline phosphatase. But many of the time I have observed, or many of the time we have observed, that they are not doing the phosphorus level. And I think that is the main crux. So, which are the other investigation apart from these basic investigation we should emphasize now?
Yeah. So, we know, we have discussed that calcium, vitamin D deficiency is the most common cause of rickets, and even in calcium vitamin D deficiency, the basic thing which cause the rickets is the decrease in phosphorus, because vitamin D deficiency will cause a decrease in calcium as well as a decrease in phosphorus.
Yes.
So your initial panel of investigation is always, almost in all cases of rickets, is going to show you a low normal calcium and a low phosphorus, despite whether it be a calcium deficiency rickets or a vitamin D deficiency rickets or a hypophosphatemic rickets, the phosphorus is always going to be low or low normal.
Low and low.
Now the most important thing which you should remember in this situation is that you should not interpret the phosphorus based on the lab value, because the lab almost always gives the adult phosphorus values, which is always lower than the child's phosphorus. So children's phosphorus levels is age dependent. It is always higher than the adult phosphorus. In infancy and in toddler age group, it is actually double of that of adults. So adults' upper limit of phosphorus is somewhere around 4.5, whereas in infants it is around 8. So a 5 or 6 phosphorus will be low for an infant, whereas it is normal
for the adult.
It is normal in an adult. So the phosphorus, one is that I think the basic panel of investigation you should always do is a calcium, phosphorus, albumin, alkaline phosphatase, creatinine, and a hemogram. That should be minimum investigations you should do, plus an X-ray.
Okay.
So calcium, even if you don't treat, even if you treat a hypophosphatemic rickets with vitamin D minimum dose or not an overdosage, you are not doing much harm. But if you are missing a renal rickets, you are not doing your creatinine, and you are not suspecting a renal rickets, you are prolonging the renal failure of the child. They can present with isolated rickets.
True.
So creatinine is a must in the panel of investigation.
Yes, it should be must, because many of the time even a pediatrician or a general physician don't suspect that the child may have any kind of renal problem at such an early age. So that is the take home message we can say, that we should evaluate renal point of view. But in again the renal rickets, there are multiple diseases. So sometimes like renal tubular acidosis and other, in which VBG, so blood gas analysis and other things.
Yeah, that may be available only in a specialized setup, but at least you can do a potassium. So if potassium is normal, severe degree of RTM will be mostly unlikely. Yes. So creatinine, if you include creatinine, potassium, calcium, phosphorus, albumin, alkaline phosphatase, creatinine, potassium and hemoglobin, I think it will cover majority.
Okay.
And if facilities are available, it's always good to do a 25-hydroxy vitamin D and a PTH. Okay. And rarely in tertiary referral centers we may be doing FGF 23 or 125 and all to find it. But basically, because this creatinine, potassium is easily available, only because you are not suspecting, you are not doing.
Yes. Okay. So the last part regarding the treatment aspects, as we know, the nutritional is one of the most common cause. We should supplement with the calcium and vitamin D supplements. But if the patient is not improving with that, we should suspect the other cause. So suppose if you are diagnosed with hypophosphatemic rickets or renal rickets, so what should be the line of management? It is directing towards the etiology, or is there any advanced treatment, like as we are going to talk on that subjects in ESICON? So any treatment in advanced management apart from calcium and vitamin D supplementation?
Okay. Again, since nutritional calcium vitamin D deficiency is the commonest thing, we do now previously we didn't have any guidelines as regarding the treatment of nutritional vitamin D deficiency. People used to give 3 lakhs IM stat,
Yes.
vitamin D sachets over prolonged periods. We didn't have any guidelines, but now guidelines are available for treatment of rickets.
Yes.
It is 2000 IU per day in infancy, 3000 IU per day till 12 years of age, and 6000 IU per day beyond 12 years of age for 3 months.
Okay.
So the recommendations are now very clear. That's an international recommendation which has been accepted. So you can always treat that, but in situations where you don't know whether the patient will come for follow-up, still you can use this 3 lakh vitamin D IM injection single dose, but only very cautiously because it has been associated with hypercalcemia and complications of vitamin D toxicity. So if possible you can avoid, but if you are not sure of the follow-up, you can always give injection vitamin D. It's better than not treating. But if you are not responding to the ordinary calcium vitamin D treatment, you should suspect hypophosphatemic rickets, and if you are suspecting hypophosphatemic rickets, the treatment is not very satisfactory because there are many complications associated with you have to replace phosphorus and 125 dihydroxy vitamin D, but it always produces secondary hyperparathyroidism and renal calculi and all. And so the monoclonal antibody against FGF23 has now been approved, mirosumab. But then I don't think it is available in India, and it's not a wonder drug or anything like that. It is still recommended when your conventional treatment doesn't give you the appropriate results. So it is not that it's a first line drug, even in countries where it is approved. So it should be reserved for those patients who are not responding to the conventional treatment with phosphorus and calcitriol in case of a hypophosphatemic rickets. And again, hypophosphatemia rickets you should diagnose only in a vitamin D sufficient child. In a vitamin D deficiency, the phosphorus will again be low because of the secondary hyperparathyroidism. So diagnosing hypophosphatemia in presence of vitamin D deficiency is a wrong thing to do. So you should correct the vitamin D deficiency and then only diagnose hypophosphatemic rickets, because you are going to put the child on lifelong phosphorus and calcitriol. So if possible, you can refer for a genetic testing to confirm the diagnosis of the various varieties of hypophosphatemic rickets.
Okay. So again, one last question, ma'am. Just want to like those who are general physician, whom to refer? That is the big question, because as the rickets is handled by pediatrician, also as an endocrinologist. Sometimes they go to the orthopedic surgeon. So who is the ideal one, or what should be the step for the general physicians or point of view?
For treatment of calcium vitamin D deficiency, probably the pediatrician can treat.
Yes, definitely.
So, and if they are not responding in 3 to 6 months time, definitely they should be referred to the endocrinologist. And it is the endocrinologist to take to work with the orthopedician to see whether the child requires any orthopedic intervention. Because before 4 or 5 years of age, if you treat your rickets medically, the deformities are going to improve. So only if it is not improving around 4 to 5 years of age, you need an orthopedic set. Sometimes they may require braces and all in the initial thing. So you can work in association with the orthopedician for that. But primarily it should be the endocrinologist who should be working up for other causes of rickets. And in cases where you are thinking that the rickets is not responding to your conventional treatment, and also please never over treat vitamin D deficiency rickets, because people will be giving 60,000 every day for 3-6 months. Child will come with hypercalcemia and vitamin D toxicity. So vitamin D toxicity should be avoided. The guidelines are available. We can stick on to the guidelines and then treat. Thank you.